Welcome, everybody. Michael Arnold Mages. I'm the interim director of the Center for Design, filling in for Paolo Cucciarelli. We also have with us Stefania Ciliota Chehare, associate director. And we're very excited to bring a great panel today, looking at interdisciplinary research between several different disciplines that CAMD has under its purview, and healthcare, as well as some great folks who are outside of CAMD who are doing innovative work around the globe. Just to give you a little bit of introduction to the Center for Design, we're both a place where people can come to collaborate, as well as a platform that hosts interdisciplinary events like this one, and supports interdisciplinary research between creative disciplines and other parts of the university. And we're a hub to attract external actors throughout this different sectors that design integrates with, as well as different organizations throughout the globe. We have partners across the entire university. Here are just a list of some of the disciplines that we collaborate with here. And yeah, we host a number of pretty great projects. This is a design and data visualization. We recently hosted a design and healthcare hackathon where students and faculty redeveloped the physical design of the central line kit. This is a recent project by one of our faculty fellows, looking at styrofoam and various waste products that was at the Venice Biennale. Design and robotics, design and intercultural conversations, a workshop series run by our own Stefania, as well as a number of different workshops and projects that we host through the Center for Design. In addition to some of the work we do, we also host a number of archives. These are some screenshots from the Data Sonification Archive, the COVIC Archive, and our the vocabulary around design. We hosted a track at the last Design Research Society conference on meta design, as well as a platform that was developed during COVID, Designing for Emergency. Yeah, so that's just a brief overview of some of the work we're doing. We're very excited to be here with our distinguished guests, Dakuo Wang, Cecilia Landa-Avila, Jen Briselli, Jessica Floeh, and Susan Mello right here to my right. We'd like to kick it off with letting each panelist give a little bit of an introduction to themselves and perhaps a project they have worked on where they've integrated design with healthcare. Jen, would you be able to be the first one to go? And then we'll hear from Jessica, Cecilia, Susan, and Dakuo.
Sure. I'm thinking, what did I do to deserve the first batter position? But I'm happy to.
Well, you're first on my list of. So thank you. Jen's recently started up a great new endeavor. Formerly head of design for MatPow, now head of design for topology. I'll let you give the whole speech.
Happy to. So hi, everyone. Good to see you all. And hello to whoever might be watching this later. Yeah, as mentioned, so currently co-founder and principal strategist at a tiny little firm called Topology, but was most recently before that at MadPow, and in the last few years, chief design strategy officer there, but spent many years at MadPow. And that'll be relevant to today's chat because anybody who's familiar with MadPow knows that they've done a lot of work in healthcare over the years. And so that was really formative in my practice as well. As part of Topology now, we do a lot of work that I would say is similar-ish, with a lot of focus on experience strategy and everything that entails, so systems thinking and service design and so on. But more so than in maybe the past, now I'm able to also fold in my own personal background and links to things like learning and complexity science, which we all can see from even that quick presentation is increasingly relevant in the craft and practice of design and design research. So I guess I'll give a brief, because you mentioned a project, just to put some context around it. Where I've been spending a lot of time and energy thinking lately is where even design fits into this conversation, because design itself sort of is its own meta practice that doesn't have its own subject matter, but it does if you know, so I won't belabor that, but one of the projects that always sticks with me was actually work we did at MadPow, which was with Exact Sciences, who is a life sciences company, and they make Cologuard, an at-home colorectal cancer screening. And I'll give you the high levels, but this may be interesting for future conversation. They were very interested in understanding the experience around using the at-home screening, obviously wanting to ensure that it's a good experience, but even more so understand when people do and don't or are not able to complete the screening, why, what are the factors. So from a highly reductionist point of view, you could have said this was a project focused on increasing compliance or adherence, you know, in that kind of bucket, but it really was so much more than that. And why it was so intriguing was because it gave us the opportunity to zoom out in both time and space, which we all hear about all the time when we think about systems and complexity, and really look at what is happening upstream and downstream from that experience, as well as what's happening in the broader health ecosystem that would influence an individual's likelihood of completing this super important preventative screening, which was often an alternative to a colonoscopy for folks who either could not or were not willing to complete that very important preventative screening. So I'll spare all the details, but to say, the insights we uncovered, which included a ton of different approaches, very mixed methods approach from an experience research perspective, as well as some others. We uncovered all kinds of interesting insights, and we were able to work through some solutions, none of which included a screen or a physical product, but were really more about programmatic learning approaches and mindset shift. And that was, to me, where the future of a lot of this craft points, even though, of course, we still engage in making. So that was one of my favorites, partly because the stated goal was, can we figure out why more people aren't successful at completing the screening, even though they've indicated the desire to do so? But the secret victory was in helping the organization, Exact Sciences, learn to be a little bit more experimental, test and learn, figure out what kind of safe to fail interventions they could try, which made this whole process sustainable and scalable over time instead of solving a point solution. So I'll stop there. Good to see you and meet you all. I think next up was Jessica, am I right?
That's right, yeah. And you said that design doesn't really have any of its own, it's sort of this referential discipline, but I think that operating in uncertainty is one of the key strengths of design practice.
Exactly.
Maybe we can return to that a little bit later.
Absolutely.
Thanks, Jess. Thanks, Jen and Jessica.
Awesome. Hey, thanks so much, everyone. I'm excited to be here. I'm Jessica Floeh. I'm a founder at Patient X Design, which I founded in 2016. I've been exclusively working in healthcare product design for 13 years, and then went independent because that was kind of what I was doing anyway within organizations, was kind of operating at these healthcare organizations sort of as the only designer. Formerly, I was a lead healthcare experience designer at Intel, and I've also just hopped around different startups, and have lately been working with Abbott Diabetes Care. And I actually have a few slides because there's two projects I want to quickly touch on and share with you all, and that I think just highlight a few key elements and differences between the two. So I'm going to share my screen. Let's see. Are you all seeing it?
Looks great.
All right, great. I'm going to share this. So So yeah, I'm a healthcare product designer, and I do want to do an official thank you to Dr. Michael Arnold Mages and my first insulin pump. I met them around the same time, 17 years ago, and they are a key part to getting me on this journey. So I met Michael at University of Colorado at Boulder, and I took some classes in digital arts, and I was really able to see under his guidance that this was a space that I was really interested in and I had some skills in. And at the same time, I also started using, I have type 1 diabetes. I've had it since the summer before I started preschool, but it was only until I was in college that I started using an insulin pump, which is something that you wear on your body and it delivers insulin 24/7 essentially, instead of taking injections. But this insulin pump, you do have to reinsert the site every 3 days. And when I was doing this and also studying in these spaces, I was just realizing how terrible the design was actually, and how stressful it was. I would be pacing back and forth doing this insertion process, and I thought to myself, hey, I could be part of making this better, and I want to make this better. And so then I actually pursued graduate programs, and I was fortunate to get into Parsons New School for Design here in New York, which is where I'm currently based. And one of the projects actually came from my graduate studies there that I'll be sharing. So I'll be comparing elements of 2 successful case studies. So the one on the left is what I was referencing related to my graduate studies that then became a side business. And then the one on the right is some work that I've done more recently with Avid Diabetes Care. So the one on the left is insulin pump fashion design for self-acceptance. And the one on the right is continuous glucose monitor UX for smart insulin dose logging, essentially. So this was a project that I did a couple of years ago, and I was struggling at picking one, so I thought I'd pick 2 to talk about, and kind of compare and contrast the 2 of them. So the audience was, is the same disease I happen to have, type 1 diabetes or insulin-dependent diabetes, and different products and needs. So in the first one on the left, I was specifically focusing on psychological aspects and impacts of insulin pump or medical device design, and specifically for women, because there's studies that show that there's more issues related to body image and fears of social stigma, and then also just general frustration with the wearability of the pump. This is actually a stock photo that I found yesterday, but it was interesting because it shows this woman has taken her insulin pump. I know she was storing it in her cleavage, because a lot of women do, because a lot of women's clothing don't really have pockets. I mean, more and more today, but it's harder for women to sort of, have these devices be on their body. And so and there's more shame involved. And so kind of hiding them in nature's pocket was something that I was seeing. And you see that here, she's taking insulin and putting it back in. And then on the right, this other project was the alternative to an insulin pump is multiple daily injections, and you can do that through syringes or what they call insulin pens. And one of you're doing this multiple times a day, and Abbott Diabetes Care makes a continuous glucose monitor, but they had a partnership with Novo Nordisk, who makes insulin and these insulin pens, and they had this partnership, and the problem space we were looking at that they had already had a solution for was they had this smart NFC insulin pen that when you took insulin, it would record that, and then you could scan that with NFC technology on your device and get that data into your CGM app. So this was really helpful for people that so people wouldn't have to do that manual logging. And one thing that I wanted to call out is that it's been kind of this interesting contrast of what I was able to do in kind of an educational environment, and the capabilities that I have as a designer and what that means in certain spaces, like academic spaces versus corporate spaces, right? So I have the same capabilities, but what I was kind of able to do, my roles and responsibilities were totally different. So on the left, hanky pancreas, I was identifying the problem space, I was creating the questions, I was doing the research, I was exploring, doing all of that. And on the right, I was a UX designer, UI designer working on a specific flow for the mobile app experience. So, and I was observing research behind a one-way mirror, but someone else is doing the research. So it was much more removed. I was playing the slice, right? The solution was already defined and I was executing on it essentially with a team. But they're both success stories for different reasons. You know, the Hanky Pancreas, which is what the name of the company that I started from these fashion accessories, was very personally successful for me and meaningful to me because I had these connections with I was hand making these products and shipping them to people with diabetes and having, you know, developing friendships and actual connections of the people, you know, actually wearing this thing that I made. And I also earned innovation awards. I was a cover girl on Diabetes Forecast magazine. I was on CNN. It was this kind of unexpected result. And it actually led to every opportunity I've had in healthcare design. And on the right, you know, I've been like, what was this successful? Do people like it? It was kind of like, you know, it hasn't been much follow through, but people apparently love it. And the integration significantly, there's a study that's been shown that this integration has significantly improved glycemic control and also reduces the number of missed insulin doses. And it's available in 19 countries. I don't know if this will work, but this was kind of a sweet video to just see someone actually going through the UX flow, but and these small moments of delight that I participated in. Can you guys hear this?
That is so cool. So I'll put my lid back.
So that's the insulin pen.
Oh, I'm really liking it. So for this next part, I'm going to screen record. Here is my LibraLink app. I'm going to go down here to insulin pens. So we can connect, review, and share. So let's get started. So I have a Novo Pen Echo Plus. So hold your pen flat against your phone and hold steady until the scan is complete. I added my pen. Oh my God, you get to pick your color, blue. And it is rapid acting insulin. And it is Fiasp. Oh, Fiasp is actually there, wow.
Anyway, so I don't want to, you know, take too much more time, but basically there's just these moments of delight of picking the color pen, these things that I influence in that flow. It feels like this small piece, but I think what I was reflecting on here is that success looks different, you know, in a corporate setting versus sort of a personal academic setting that then becomes your own thing. But neither are wrong. And anyway, I wanted to share reflections of those two things. I thought we could get into those topics.
That's great, thank you. And yeah, that's just wonderful when somebody meets your interface and there's that feature there and they just go, ooh,
yeah,
you know, just so satisfying. It's like, yes, I worked for hours for
yeah,
that there. You know?
Exactly. Yeah, just those moments of delight that are, you know, the bar is kind of low for that, but it was nice.
Very gratifying. Cecilia is a researcher at Loughborough, also looking at coincidentally design in healthcare.
Yeah. Hi. Can you hear me?
Yes.
Yeah. So first of all, thank you, Michael, Estefania, Paolo, for the invitation. I'm very happy to be here this evening. For me, I'm based in Loughborough in the UK. I'm now assistant professor in systemic design, but most of my research is in the healthcare sector. I have been here for the last 6 years, but I think my journey in design and healthcare started 12, 13 years ago. My background is in industrial design, so I did projects especially for people with motor disabilities, assistive technology. And then I moved into user experience and healthcare, human factors, and ergonomics. So I spent quite a few years developing a lot of electronic records. So I think I know what you mean with all this situation, especially for people with autism and their carers. I think was my first approach to kind of diversify the access to technology. And then I moved finally to academia and I decided to stay here. And I move also in the world of systems healthcare and social care, because I spent a couple of years working for governments for social care programs. So it's when I finally kind of I'm bringing all of these things into kind of one of my practice. I also 4 years ago, just before COVID, I founded Relaesa, which is a Latin American network of mainly healthcare professionals and a couple of academics in healthcare and human factors. And what we want is like to provide kind of bit of training and also learn, and most importantly, it's a community of practice, because we need to learn from what actually happened in practice. Is kind of contrasting work as imagined by academic against work as done by them. Today I decide to share, I don't have slides, but I'm going to just share a link to the project that I'm also currently working and it's called Decode. And actually this project about transdisciplinary, we are a group of many universities. We are working with also a couple of hospitals, people from medicine, of course, but then also computer scientists, because we are trying to understand big databases about multiple long-term conditions, creating these visualizations of how trajectories evolve over time. Then the world of design starts by some people doing more of the graphics and try to make this information and communicate that in a way that is understandable. We are doing a lot of storytelling, because one of our main users are people with learning disabilities. So of course they face, or we have created, it's not that they face, we have created more barriers for them to understand many of the things and kind of interact with many of our systems and services. So central in our practice is that whatever we are designing, they can use, they can understand, and is meaningful for them. So I'm leading all the participatory methods with them, with multiple stakeholders. We started running interviews one by one, start to also, and it's when I have, of course, those concerns, but it's when I identified that a lot of design methods are actually creating more barriers for participation, are not really accessible and inclusive. And we spent almost the first year just into adapting the methods. That is so much more than just making easy read, or so a lot of work has been done into use kind of this world of boundary objects, and try to create and use different ways of communicating and bringing people into the same conversation, because we are halfway into the project, but the last study is something similar to a work cafe, in which we will bring people with learning disabilities, their carers, healthcare professionals, social care professionals, tech innovators, because we think and we believe that this AI algorithm and this place can be used and to develop new technology, and also policymakers, because the way that people work together need to change. So we need to change something there. So we are still figuring out how they can sit in the same table, have a conversation in which all of them have the same power and confidence to express anything that they want to express. And I think that is kind of my main role, and also kind of the area that I'm now specializing a bit more. And I use a lot of system thinking methodologies to kind of help people understand that, yeah, healthcare is complex, that there are many people, many stakeholders, and there are many priorities that are very conflicting. And sometimes we need to reconcile our values in order to try to create this final decision about what to do next. So yeah, I think that it's me, that is one of the projects, and yeah, I don't know if there is any questions or anything.
Well, we're going to open it up for questions just as soon as we we're gonna talk to all the panelists, and so I think if you do have a question, just hang on to it, maybe note it down and remember it, or put it in the chat too if you are, and we'll we'll come to those just as soon as we can. Thank you, Cecilia. That's fascinating. And I think, you know, the challenge of these design methodologies, you know, I don't know, work with them all the time. You know, you think they're so open and easy for a group of people to use. But I also had a similar experience at a community meeting where nobody wanted to touch the Post-it notes or the markers, you know, and there's some real barriers to and they can be intimidating, these tools that seem so open. So thank you for bringing that to light, and we'll look forward to digging into that just a little deeper than my quick thing I noticed and related to there. Susan, shall we a different kind of work than everybody's been sharing, but just fascinating nonetheless. So yeah, can you share your yeah, well, you're already up, so.
Getting there. There we go. So, thank you for having me. I'm Susan Mello. I'm an associate professor in the Communication Studies Department here at Northeastern. I've been here since, which is wild, 2014. So it's almost going on 10 years now. And I met Michael and Estefania during an arranged marriage from the dean's office. And unlike some of the other arranged marriages, ours has actually been quite successul. So I'm really happy to be here and be working with them again on a different project, or at least sharing a project that I've been working on with a faculty member in the Bouvet College of Health Sciences here at Northeastern. So my research is predominantly at the intersection of media, including mass media and social media, risk perceptions, public risk perceptions, and health behavior change. So we did, during COVID, we had the idea of looking at communication from the CDC and World Health Organization that was being distributed during Instagram. So this was pre-AI, and we used some content analytic methods, which now feel a little bit arcane and outdated, but we're trying to get up to speed with that. Hopefully we can maybe talk to some of the people who are working in industry to get some better insights on how to do this more effectively. So back in early 2020, the WHO and CDC had roughly 12 million combined followers on Instagram. They had less organizational activity on Instagram than Twitter. However, research has shown that there was a lot of public engagement, including likes and comments, and the distribution of personal prevention information through this social media channel. So Elizabeth Glacki and I decided that we wanted to elongate the time frame. A lot of the research that was coming out was only focusing on the first couple of months of the pandemic. So we decided to look at the first full year of communication. We included video content where a lot of previous research was only looking at captions or static posts that were being made. And we assessed all of the messages that were posted by these two organizations during that 1 year period using different theoretical models of fear appeals, called the extended parallel process model, and crisis communication frameworks that are enacted by many government organizations, including the CDC, to structure their crisis communication. So as I mentioned, we had slightly arcane methods. We hired some students here at Northeastern, which was actually really difficult in the midst of the pandemic to scrape a data set for us from Instagram, including captions, visuals. We also got comments, which at the time was a little bit scary, but could make for wonderful analysis to see how people were responding. We had 1,000 posts. The content analysis looked at 15 different message features. We hired some coders. And then this is a very small snippet of our code book, but we coded for which populations were noted as being susceptible on what characteristics, the severity of the consequences of exposure to COVID, whether it's physical, mental, and the degree of the severity, efficacy in terms of how confident people should feel in being able to reduce their risk, and how confident they should be in the responses that were being recommended by the CDC and WHO. And then collective efficacy was a new feature for this project, which was looking at messages trying to engender or motivate people to engage in these behaviors because of their collective community effort and goodwill. So we also looked at whether or not there were information seeking cues, like talk to your doctor about COVID or whether you should get vaccinated, the preventative health behaviors, diagnostic and treatment behaviors that were being communicated, and whether or not they were being visually modeled by people in the messages, and then also cues to the credibility of the messages, including whether or not there was evidence, statistics, or whether or not they were general statements, and if they referenced an expert or non-expert. So here's just some examples of, and this is probably what would be most interesting for this group here, which is in terms of design, because I'm not a designer, I'm just evaluating the communication that was put forth. So there's a variety of different elements that were included. This is, I just have to move my little window here so I can see. So here we have within the text message, the caption, information about physical severity of contracting COVID, and then including the mask here and vaccine band-aid, showing about the efficacy of different response options that we have, and then modeling the preventative behavior, actually showing it physically here. And then here they have some information seeking cues where people can get more information. Here's another example, CDC, again, modeling preventative behavior, including an expert source or credibility cue, and talking about susceptibility of different racial and ethnic groups to COVID. Oh, and then some evidence, actually. So this is just an overview of the posts that we collected. So again, we had over 1,000 posts that we filtered down to 726 that are about COVID. So about 68% of the total posts made by these two organizations were focused on COVID. It's not surprising. They spiked during April when the United States hit a million cases, or both the United States and the world. And then again in December, when the vaccinations received emergency use authorization. Try to go through these kind of quickly. Threat information we found was actually really limited despite theoretical recommendations and a lot of the research that shows that we should be including this information. Efficacy appeals, however, and cues to action for the public were really abundant. And just get to what I think might be most interesting for, whoops, a little bit of a delay. My animations, here we go. So we had some practical implications for both the CDC and World Health Organization into what they should be integrating more into the design of their messages on Instagram. We did find that there was a lack of fear appeals that was counterbalanced by abundant efficacy messaging. I realize a lot of my language here is different than what designers are using. So if you have any questions about this, I'm happy to explain further. But what's lacking in this particular study, right? It's a content analysis of what's available on social media, but how can we couple this with what other sources of information were available, particularly from healthcare providers at the time? We're limited in terms of drawing any sort of like causal claims about what exposure to this messaging results in without further data. And then while this is adding to a burgeoning literature on official health and risk communication via Instagram, I'm looking forward to trying to figure out how to harness AI for content analysis for identifying patterns more efficiently, more quickly, right? We did this in 2020, it just got published in 2023. So we're at a much slower clip than industry, integrating that for visual and sentiment analysis. And then in terms of, say, limited threat information was concerning. Yeah, so there actually wasn't a lot of threat information embedded in these messages from the CDC and World Health Organization, despite there being a lot of early myths swirling and disinformation and misinformation about COVID. It could be that the world is already very anxious about what was going on. So one thing that we lack in this, and I don't know how to address it necessarily, is that we don't have insight into the health agency's strategy of politics, right? What's involved in their communication plan. And that may mean that we need to add some more qualitative collaborators who can go back and look for other sources of information to sort of cross-reference what we see and what their intentions were. Okay.
Great.
Yeah.
Thank you.
Thank you.
No, it's super interesting, and I know it's a little bit different, but you know, we were hoping to have a diversity of practice and research on this panel. So thanks for bringing this, and yeah, Jessica just asked about threat communication, and I was curious along the same lines about fear appeals, but maybe we'll just hold on to our curiosity for just a few minutes while we hear hear from Dakuo, who does do some of this AI work that you mentioned. I'll let him describe it though. Dakuo.
Hey, thanks, Michael. Thanks, everyone, for joining. I also have prepared a very short slides. Let me share my screen. So my name is Dakuo Wang. I'm currently an associate professor in comedy as well as in Korea. So it's Northeastern's design school as well as the CS school. Before joining Northeastern, I was at IBM Research leading product team, product design and research team focusing on AI-based product development. My research background was from human-centered computing, but then after joining IBM, I'm also working a lot on AI. So now I, consider myself in this interdisciplinary area with HCI, AI, and also group collaboration. My research has been primarily focusing on human-centered AI, but I want to skip all these slides, jump to here. So my unique approach to study human-centered AI is that I propose human-AI collaboration as the ultimate design goal for building and researching human-centered AI like systems and algorithms. The problem of today's research as well as practice in the real world is that the user researchers and the machine learning researchers don't talk to each other. We each are motivated by a different incentive mechanism, or we publish papers or come up with design guidelines, but these knowledge are really needed by the other community. So that's why my work, I believe, are trying to bridge the gap, right? So we work at these two lines at the top and the bottom. At the top, we want to bring the knowledges, mostly domain knowledges, user needs from user studies, from the HCI research methods, translate them into new data sets, new tasks, and new model design knowledge, bring them to the machine learning community. From the bottom line, once there are novel technology, novel algorithms invented by the machine learning community, we should bring them back to the real world applications. It's not the algorithm that our target user can consume, can use, can get benefit. It's actually the system. And we need to design them as a system so that the system can serve as the interface between the human intelligence and the machine world. I don't have time to go through this entire slides, but just to mention two projects that I'm currently working on. One is mental health, like a machine learning model, large language model. In this particular work here, we benchmarked all the existing large language models like GPT-4, GPT-3.5, Alpaca, Fluent-T5, Llama, all these kind of things. And then using multiple data sets and the various tasks on these data sets. So the whole, the task is very simple. There are existing data sets that's trained to predict whether this particular user has a suicide intention or not, or having different level of stress level, or having depression or not. So these kind of different tasks, purely using the text-based message they posted on a social media platform like Twitter, Reddit, or various other places, right? Using those things, we can benchmark, to the roles. Those are the different models that are existing out there. And what we did is we trained our own large language model here. As you can see, if we can fine-tune our own large language model using this in-domain dataset, it can outperform those, very huge GPT-4 even, right? And also it has a generalizability, meaning it is trained on a couple of different data sets, but in the GPT-4 kind of like context, it's not doable. Okay, so from this kind of like model work, what we can do to operationalize them and then bring them to the users. What we are currently working on together with researchers and designers and medical experts is that we believe there's opportunity for bring those large language model technology into the real world, not to replace the medical experts who are already doing this kind of task, but rather building those AI systems as a supporting system to support the human-human communication or human-human collaboration. So in this context, right, or in this chart, what we are showing here is the surgical team versus patient, but you can also imagine them as, you know, a psychiatrist, right, or a PCP. There are always this need that, you know, patients and medical experts, they need to have periodic communication, but the existing way of doing SMS or we're using MyChart, using the Epic system to make phone calls, it's not that efficient. What if we can build a whole system leveraging this kind of large language model, like ChatGPT or various other large language model, but also together with the medical expertise, right, provided by human experts, and then we can provide to the end user, the patients, a very low cost Alexa kind of like a smart speaker, put them up there in their home for long-term deployment. And this Alexa smart speaker can embed the large language model and then provide proactive interaction. It can provide, for example, daily check-in. It can provide kind of like emotional support as well as various kind of functional support. We know that the current practice of, you know, human-human communication, the limitations at the surgical team or the doctor side, right? Because they don't have enough time to really monitoring hundreds of patients at once, right? But with a larger model with AI, we can provide them a much fancier visualization dashboard so that they only need to look at those aggregated message together. They only need to look at the summary from the conversation interaction between the patient and our system. If there are certain things that they need immediate reaction, then they can pick up phone and then make that phone call for with those 5-10 patients out of that 100 patients. That's one of the projects that I want to present here is building large language model and then bring those large language model to the real world to support the human-human communication in medical healthcare setting. The second project is this one. So our idea is purely focusing on the clinical setting. This is clinical decision support. How can we bring AI to support the medical experts within the hospital clinic setting to make a better decision, right, regarding various kind of disease? Here, we compare our proposed approach here to the left. We call it a human AI collaboration design target versus the existing approach, the traditional AI systems that are being developed and deployed into the real world, right? They are really leading to a human AI competition kind of like a paradigm. That's why doctors and the practitioners don't want to use them, right? Because it's challenging their authority with a very low performed accuracy. So it's not accurate, but adding more extra work and then, really annoying. And so that's why people don't want to use it. They very often abandon it. We argue that in order to provide this human AI collaboration paradigm, we should really not focusing on the final decision-making. We leave that final decision-making authority to human. Rather, we design AI to support their decision-making process, the prior steps before they come down to that final decision, right? So we leverage the existing theory and research work from the human workflow, like various research from the past decades has been proposing how human collaborate, how human themselves making medical decision making. What are the steps? What are the hypotheses? What are the challenges and uncertainties getting involved in it? Right? Why don't we build AI to integrate with the human's workflow rather than pulling human out of their workflow to adapt to AI? So that's what we believe should work, right? So what we are doing, even further, down to the ground, we're building this kind of visualization system. trying to integrate them into the existing EHR system. So as you can see to the left, this A and B section, these are existing EHR system like Epic or other system, right? To the right, this C section is what we are kind of building. We want to use this kind of like a visualization to show to the target user not only this current like a 13 as a risk score, which is not explainable, meaning nothing to the doctors, but rather to also show them the trajectory into the next 5 to 10 hours. So this in particular is a sepsis, right? Is sepsis early prediction. And then we are not saying like, the doctor, you should listen to us, right? You should make a decision right now. But rather we tell them what's the uncertainty as of now, and what kind of information you can gather to reduce the uncertainty. If you can reduce the uncertainty from this gray area like confidence interval to the red area like confidence interval, very likely this uncertainty reduction can also help the doctor. That's not only AI's uncertainty, but also humans' uncertainty, right? Helping doctors, human doctors, to reduce uncertainty, that's what we want. And then whether this patient really have sepsis or not, that's humans' final decision to make. So using such a way, from our preliminary user study, it seems the doctors, the target users prefer this current design way better than the existing one, where they only provide this sepsis risk score as a red like big dot there. Okay, so again, from this work or this line of work, what we are trying to do is bring the model into humans' work practice, right? So this is really what we're doing here is user-centered design, right? What Don Norman has been arguing for the past 40, 50 years. But now that everyone are so fascinated with AI, what we really need to do is still like stick with the user-centered design UCD approach, and then bring AI to the places where human needs them, not bring human to the AI where AI needs them, right? So that's what we want to argue here. Thank you.
Thank you, Dakuo. Really, really fascinating, fascinating stuff. And I think it highlights. I was as everybody was talking, what is the relationship between these diverse projects and approaches? And I think uncertainty is one of those things that shows up in healthcare again and again. And your work really highlighted that. But I mean, you come back to Jessica's work of like somebody feeling uncertain about their how am I going to use this new thing that I got, and now I have to I have to redo my my site, every 3 days, and do I feel the kind of bodily uncertainty that exists there, or the work you were talking about, Susan, with how do we respond to COVID and see these things modeled for me? Does that help reduce my uncertainty? And I was wondering, maybe just kind of I do want to get to the questions of Susan's definitions, but since we're on this like uncertainty thing, I'm still a little uncertain about these different terms. But how do you guys, when you guys are working, and maybe we could loop back through people who are interested in answering this, how do you approach communicating uncertainties, probabilistic information, or like an uncertainty in a process or structure that somebody might have to engage with, decision making through your designs, and how to do this? Maybe how do we do this without increasing the anxiety in patients who are stepping into this world that is not their world?
Is that posed at any of us? Should I just because I was actually thinking uncertainty was like the marquee phrase like across all of these. So I'm so glad you hit that too. And the one thing I was going to say, and then you teed it up perfectly, was whenever people start talking about uncertainty, especially from a design practice, I find one of two things is happening. People are skipping away ahead to try to reduce the uncertainty, which is like human nature, right? Or they're basically pretending it doesn't exist by trying to take zooming out to a systems view. Of course, we're all much more interested in a holistic systems lens now than say 10 years ago, but what you lose at certain resolution altitudes. So in some ways that's appealing because you're looking from farther away. It may be a lower resolution, more pixelated picture, which feels a little calmer. You don't have to see the granular detail of how much uncertainty really exists. And I was just saying to somebody earlier this week, I think increasing our tolerance for uncertainty is so critical to the practice. Now, not for patients, right? Like not for the users, maybe, unless that's part of their role as a stakeholder, co-creating some kind of future for themselves, and that they're in this decision-making process. Then maybe I think there's a role for us to help also support. How do you maintain a level of uncertainty, build a psychological tolerance for uncertainty that allows us to then have calm and productive, co-creative kind of interactions? And sometimes it might be even just the data viz like that we just looked at, that hurricane path model is something I find a lot of people find resonant, especially with futures and foresight work becoming more present in the world too. People are much more comfortable with that. But anyway, if I could just say one thing here, it was largely that it kind of like before any of this becomes like a relevant topic, it's the question of uncertainty tolerance. Can we even tolerate it long enough to figure out how to work within it? I almost wonder if that for me becomes more important. And then we get to the task of communicating within it, reducing it where we want to reduce it, maintaining it and swimming in it where we want something to emerge and we want to preserve the chance for emergence to take place. So uncertainty, intolerance is maybe where I'd love to hear from the other panelists on that.
Me too.
Yeah, so I can quickly respond. I think for I'm not a medical expert. I don't have much like experience from the medical health kind of background, but from the literature, from the textbook I'm currently reading, doctors or the decision makers, right, in medical decision making, they always need to embrace some degree of uncertainty, right? So there's no way that you can really eliminate that uncertainty. That's something that I think many of today's like AI algorithm researchers or system builders are not appreciating, right? When we do something, we really want to say, oh, our AI algorithm is 90% accurate or 99% accurate, right? So with a human in the loop, for example, we can improve that accuracy to 100%, right? But how can they measure that 100%? They use existing training data, but not really like understanding that patients, your future patients coming in are not the same as the patient that's from your historical data, right? So if we, not if, but once we start to propose or move forward this research agenda to communicate, not even to the target user, but within the research community, that uncertainty has to be there, right? So you need to acknowledge accuracy is not the most important. Uncertainty is equally important in design, in research, in system building, in users' mental model. I think that piece is still missing. But once we start to move forward with that, I think it can, I believe it can significantly improve the success rate of the system that we're putting forward to the real world. That's my 2 cents. Thank you.
Cecilia?
Yeah, I think I completely agree that we need to be more comfortable in uncertainty. However, I think my experience so far with medical stakeholders is that they don't really manage uncertainty very well. They still have this mindset about evidence-based. I mean, even right now, they still ask us sometimes for a systematic review to make decisions about some design alternatives. So that can give you a kind of a glimpse of how the mindset don't work. I completely understand, right? This tension about safety against innovation that they have. So they don't want to risk anything. So that's why, I don't think this is like a very quick or easy answer, but what we do is we focus into things, into helping to visualize the system, because the more information they know, even we say the map, the visual is not the territory, they start to feel a bit more comfortable to know that, okay, if something goes wrong, it's not my fault, because there is a blame culture still in healthcare, right? So they need to find who made the mistake and do some training or whatever. So that is kind of one approach that we use to map, to help them to understand that there are many pieces trying to work together, and that most importantly, they want to do things well. And the other is also we use a lot of storytelling to communicate dilemmas. So when we face with these tensions and conflicts, they start to notice that there is no like quick answer to that. So, and one example in another project that we did also in with COVID passports, we have this tension about this dilemma of convenience and privacy of data. So we use stories, and then we face the character that in that case then they were there to this question: what would you do, like if you face these two values? So that is another strategy to help them to start to know that there is no one easy answer, that there is a lot of things that they don't know, and to face like a small, more manageable situation in order to make those decisions. But there's still a lot of things to do about that.
Yeah, Cecilia, I'm glad you brought up the stakeholders, and because that's where my brain went too, is thinking about, working in a corporate setting, you have product managers, you're talking to people that are thinking about the business side of things and the risks there, time to market, talking to legal teams, talking to people representing a regulatory point of view, right? That's sort of that I really loved how you talked about that and represented that sort of space between how do you balance safety and innovation. I think that's just so prevalent, right? For good reason in healthcare. One thing that I've been doing in a recent project is working and creating a decisioning workflow and helping my stakeholders understand strong rationale, like really trying to understand design decision rationale and clarify that, and really weighing our information in terms of what is so defendable, right? Like accessibility guidelines, like certain standards, like we don't need to have a conversation about these colors anymore, right? Like these don't pass accessibility guidelines. There's certain things that you can just, that information is going to be so much stronger and have so much more weight versus, okay, maybe we tested this in research and people loved this color, but we're not even going to consider it, right? So there's certain things it's important to help stakeholders understand and weigh the information and make those decisions and bring them along with you into, okay, I can argue that as well, right? To the people above them, and that you're really equipping stakeholders with rationale, and that they can go on their own and defend, without you present in the room as a designer.
If I can piggyback on that really quick too, because I really like the culture of safety and exactitude, right? That is so like pervasive in most medical training, raises such interesting questions. And I thought I'd give this hilarious example because Jessica, you kind of hit in the same direction. And then I want to like another provocation to hear from you guys. But that example I gave in the intro, the project that I described, one of the things that was true for that organization, who despite being a life sciences organization, a corporate environment, most of the leadership came from medical and clinical backgrounds. So they were absolutely part of that culture. And this organization, and I was describing how their goal was to figure out how to get more people to actually complete the screening who had said they wanted to and just weren't doing it. We had asked them, what are you doing right now to get them when you get to that point? And they're like, well, what we'll do is we'll actually just, if they haven't completed it in a certain amount of time, we'll offer them a gift card to do it within a couple, whatever time frame. And we were like, really? You just throw gift cards at people? And then we said, is it working? And they were like, oh, we don't know. We offer it to everybody. We don't hold a control group back. And we were like, why aren't you trying to learn from this? And they were like, because that wouldn't be ethical. Because if the gift card led to somebody then completing it, and then we prevent an early cancer, or we find an early cancer, we can't ethically hold back that intervention from people. And I was like, this is not the polio vaccine, right? Like, so helping them understand like grades of risk and severity, but more than that, because we were in no position to come in and actually say what I just said to you guys sort of flippantly, like that's their moral and like ethical imperative in the work they do, which is like, we don't want to interfere with that at all. Rather, what we were able to do, and again, long story I'll make very short, was really just gently coax them into tiny safe to fail experiments, tiny little, try this with like literally a cohort of 100 people and then hold a control group of 100 and just see what happens. And they're, you know, helping them like gently realize they could embrace that. But I share that because that to me is such an example of that cultural shift that needs to happen. So as you guys were talking, it begs the question for me, if we really think about that cultural sort of piece to being a medical / clinical minded person who knows that there's uncertainty here, but needs to reduce it in some way for the efficacy and the safety of whoever they're caring for. Does this mean that it's just going as far upstream as training? Like, should we all be working to basically become folks who work in the medical schools and are helping, you know, in that way? But you mentioned dilemmas, Cecilia, and I was going to say, I don't know if you guys are familiar with the work of, say, Jack Mesereau. He wrote about like transformative learning theory, and this is my teacher background showing through. But one of the things I'm hearing is like it's a learning to be tolerant of uncertainty, but learning not in the sense of learning like transfer of knowledge and skills, but rather mindset shift. And that stuff's hard to do. But one of the keys that is usually at play when some kind of transformative, life-changing learning happens is a disorienting dilemma. Usually they happen organically, but can they be manufactured in an ethical way? And like Cecilia, even your example is like on a smaller scale, kind of that. So this just sparked that for me. I'm curious if that sparks more for you all, especially Susan, I know, because we're, you know, especially the communication of this stuff fits in some interesting ways, but.
You want to pick up there, Susan?
Sure. I'm not familiar with that work, and it sounds fascinating, and I'm definitely going to look it up about the disorienting dilemmas. I don't know how to manufacture it. When you were talking about uncertainty, most of you were talking about it from a designer production perspective. And I kept thinking, well, how does my research contribute to this, or my field? And most of my project was understanding how these two organizations, the World Health Organization and the CDC, are trying to reduce uncertainty, right, in the public perception of risk. So that's why we chose to look at the different message features for the analysis, which were, if you're uncertain about, you need more information, here's where you can go look, right? Information seeking cues. The credibility cues of, is there an expert delivering this? We all know that there was some reputation issues with the CDC during early COVID. So making sure that they were including data, or did they include data to support the recommendations that they were making? Did they have data to include? And then when it comes to, and there were questions, this kind of leads into, why did we code for efficacy appeals? From a communication perspective, the theory that we use, the extended parallel process model, says that when we encounter information about a risk, and it's funny because risk and fear appeals can trigger us to think of these like drunk driver ads that we see that show like busted up cars and COVID being like leading to death and all of these like extreme examples, but fear appeals actually exist on the spectrum, right? So we can elicit sort of an emotional fearful response from people by telling them, yep, you're susceptible to getting COVID. It can have all of these negative consequences. And the research and the literature suggests that when we couple that with efficacy information, we're most likely to get a positive, proactive response, right? The question about people disengaging, that is absolutely a risk. If we overwhelm people with too much scary information and don't tell them how they can actually reduce their personal risk, then they will just focus more on calming themselves down and avoiding it and disengaging than they do on actually adopting a healthy preventative behavior. So that was sort of the driver behind why we were coding for certain information. It was striking to see that the CDC and the World Health Organization avoided giving too much of that like susceptibility, severity information, but they did have lots of efficacy information, right? So they were, again, trying to reduce uncertainty without sort of evoking overwhelming anxiety in the population because they were already getting so much information about COVID risks from other sources. That was a lot.
Super fascinating. And, you know, and maybe this question is, you know, some of us are researchers, so we don't end up dealing with the aspect of implementing our research in a particular setting. But I was wondering, like, if anybody's ever, like, these healthcare systems that we all work within and study and discuss, they are very structured and very, you know, I think I was talking with Jessica before the call, the company that she's working for was 90 years old.
100, I think.
100 years old.
Yeah.
And in that time, they get very resistant to change, and very, have a lot of like structured processes that are not friendly to innovation. So I'm wondering, you know, when you come out with a new piece of research or a new AI model that might offer like interesting decision support or a different way to engage with patient stakeholders, do you find resistances in these healthcare systems to adopting new research, new approaches to working, the adoption of new technologies? And how do you approach that? Ooh, I killed the conversation.
I'll be brief. If you guys have never heard of, I don't believe in like one framework to rule them all, but I really like the metaphor of immunity to change, which I think Robert Keegan, if you guys know his work at all in like constructive developmental theory. But when you think about resistance to change, I just have always loved that metaphor in that you've got humans and businesses and organizations, academic and whoever, have an immune system that's meant to protect something, hopefully values and core mission. But like in a human, the immune system can turn on itself, and then you've got an autoimmune disorder. And so Keegan writes about immunity to change in that way as a metaphor. Now, he's also developed a whole framework and practice and, organizational change and change management. But compared to some of the other change frameworks I've seen over the years, different behavior change frameworks applied instead of at the individual, at the organizational level, they all work. They're all just different lenses on the same process. But I think the metaphor of the immune system has just been so powerful to me that I will even sometimes just say that much, and you can generate some very interesting or facilitate some very interesting things with stakeholders to ask, what is your immune system trying to protect you against? And is that a real threat? And getting that introspection and reflection to happen can do a lot, at least I have found.
I love that. And it's medical, so it works.
Right.
Yeah.
Yep.
Yeah, I mean, change that these are really, healthcare. I love thinking about that. I mean, healthcare just as an industry has an immunity, right? For good reason, there's been like lives are at stake. And I think that becomes sort of the umbrella that you're within, and then you have corporate, if you're working within corporate organizations. I mean, the project I share was a partnership between two 100-year-old companies, right? The Novo Nordisk and Abbott were both founded in like early in the 1920s or so. And they're still around for good, because of their strong immune system. So the things that, working as a designer within organizations and outside of organizations, but always kind of partnering with them in some way, change is super slow, and it's not going to happen. It's like years, right, of kind of representing that work or adapting yourself to that environment and trying to get in those small spaces of changing, maybe just influencing, putting a little bug in someone's ear. And sometimes the change needs to come from organizational change, like new folks coming in and coming from other industries. It's not something that you can do by yourself, right? Or from certain positions, for sure. So it kind of there has to be an alignment and at a leadership level for things to really take effect. I would say it's been my experience.
I will say the last time I went to the doctor, I got a very nuanced and sophisticated patient intake form with a lot of perspective and talent devoted to different representations of identity and how those might be structured and different representations of sexuality and sexual function. But I couldn't help but wonder if the corresponding database systems that are receiving this information have also been updated, or if this is something that just stops at a door somewhere. There's an abstraction layer latent in that system that maps this set of responses to the old categories. Yeah. So I don't know. Optimistic, cautiously optimistic. I'll remain cautiously optimistic. Celia, do you also work directly with a lot of health stakeholders? Cecilia, do you find there's resistance to innovation, resistance to design taking hold in these organizations, or
yes, there is. I mean, here, sorry.
Sorry.
I feel that, and it takes me still like years to understand and to build this. But I mean, what advice that I received a couple of years ago is like, first focus of making friends in there. So it, because I was someone that I want to change, but I think from my human factors ergonomics background, that is what has helped me to open doors, even like to start with the small changes. I don't want to say, but during COVID, there were a lot of opportunities to help and to partner with different hospitals and organizations to make big changes, just to maybe rearrange, the spaces to provide like a more efficient delivery of the vaccines, things like that, very small. And they notice the benefits immediately, and they notice that even if you come from a different perspective with different methodologies and everything, you really want to help. And I mean, that the purpose, I mean, you mean well. So I think that is a way that I have been trying to do. Sometimes I'm very frustrated because, I mean, no matter how much I try to make friends, to open doors, sometimes at the end, the thing is still like a bit, difficult. The other thing that I have tried, and I think here in the UK, the context is, I as you say, I'm optimistic sometimes. So there is a lot of push about like co-production, which actually means, like using co-design. So even now, many of the grants applications, they need to have that component, which is like co-production and including people of PPI, like engaged with patients and the general public. So it's finally they are looking at, we need a partner that knows how to do all these things, right? So I mean, we are building that even like by force sometimes, and other because they are start to understand. So I think that has been kind of my strategy. And then about like going a bit to the other question is about bringing these theories of change, because of our evidence is never going to be as their evidence. But if you start to mention that this is like a process and that we have outcomes we have shared outcomes and shared purposes, that I think help us all to align in this kind of strategy, even if we are doing things slightly different. So all the time when we disagree, when they don't want to kind of believe in you, is to bring back that vision that we have and say, look, this is what we envision at the beginning of the project. This is our values and what we want to achieve, how we can make these things work, right? So it's a lot about reconcile discrepancies and all that stuff. So it's a commitment that we need to make when we decide to work in healthcare.
Absolutely, absolutely. That made me think of both like both inclusivity and making sure you're casting this broad net, or maybe let's have a less captive metaphor for getting our users together to talk about these things. But then also like all the different kinds of literacies that that are associated with this work. You know, there's like the base language literacy that people are working with, whatever the language of fluency is that they're conducting the healthcare conversation in. But then there's also a sort of health literacy and maybe specific like health language that's tied to this as well. I wonder, like maybe Susan, do you have any like effective strategies for, you know, when we're dealing with these, like something like this you know CDC or the is trying to speak over this broad audience, and this is kind of something you mentioned too, Cecilia. Are there strategies, best practices to ensure that this stuff is the most effective for the biggest group, or like what's the best practice here when we're trying to speak over varying levels of language and health literacies?
It's a great question, and it's something that we struggle with. I say we, the royal we. But I think what's the most common best practice now, I just had one of my students who took my health campaigns class and is now working for the Boston Department of Public Health, and she's doing surveys of rural populations, and she actually advocated, she wants to go and get her MPH for diversity, equity, inclusion. So she advocated to have the survey translated into 14 different languages, not just English, Spanish, and Portuguese, which are the most predominant languages in Massachusetts. But she also has worked to have the survey and a lot of the communication and promotion around it be brought down to a 3rd grade reading level, which tends to be most inclusive of everyone. So it's a challenge, and it's something that when I'm teaching my students how to develop these messages, there are tools online that you can translate to bring it down to a particular reading level. But that tends to be the most common approach. Sorry, what I didn't say was that as part of her translating the survey, the most common practice is that we actually reach out to our target populations and include them from day one. So this is rather than talking at them, we engage with them so that we're using all of their understanding and terminology and awareness of the problem to integrate into the message design from day one.
But then this, you know, this kind of comes back to this question of like institutional structures, and well, can we afford to hire an interviewer that speaks Haitian Creole or even Spanish, you know, which is maybe more common. Each one of these is like an additional budget line item that's scrutinized, and there's like a cost to that inclusivity. How do we, do you guys have any strategies for making that argument?
Show the cost of not being inclusive, which is often more storytelling than data, but we've all got the data viz and storytelling skills as design and researcher and innovation, folks. I know that's a bit of a trite answer, but it's the one that comes right to mind because I've been in that role so many times. Sure, you may not want to pay for that extra cost for translation for that small population, but let's think through whatever, if they speak the language of money. So unfortunate as that is, that's the system we still work inside right now till it all burns down someday. But basically, I think as long as whoever you're engaging with, if they're speaking the language of money, then you can speak back in that language and show the downstream impact of not taking some of those, making those small investments up front. It's much easier said than done, but when a commitment there is made, it can be effective, I think.
I think some of the challenges is that, this work that's so intimate, like some of the work Jessica showed, it really comes, it goes a bit beyond translation. This is a very personal thing that intersects with your body, that is maybe one of the most intimate things you'll do with some human beings that are not your significant other. can we just hire a translator for that?
Yeah, it's even thinking of the one thing that just shifting from being on injections to an insulin pump, there is like a language change that's kind of interesting. There's a culture that kind of comes with products and the way people talk about them, right? I would say there was more of a third grade reading level conversation of kind of before that, right? Of blood sugar, or you take your insulin, or, you know, these things that, and I went through my whole basically memorable life with diabetes, but then I get on an insulin pump and it's super clinical, right? They start using terms like bolus, basal, these things that I didn't know what they meant, which was really interesting that, you know, even just kind of this, if you're designing from this clinical space, you might forget, you know, or even just being a designer or a researcher, or the way we communicate to others, we just might just totally forget that they won't know what we're talking about. So anyway, that just made me think of that as we talk about language, that these projects have a language of their own sometimes.
It seems like Dakuo, your work too, like coaching the doctor through this difficult decision. You know, this is fundamentally a linguistic, act, right? This, it's almost like having a little parrot on your shoulder that reminds you of what the risks are or what the challenges might be for this particular confluence of circumstances for this patient. Can we embed empathy in that stuff? Is that this kind of empathy that Jessica's talking about here?
Right. So the empathy for the doctor or empathy for the patient?
I think both need it. You know, I was at a couple medical conferences right after COVID, and I think those doctors all looked like they had been to war. You know, they were just. So I think that provider fatigue and provider vicarious trauma for the providers, it's, you know, pretty compelling experience. And if what is that thing they say on the plane? If you put your own mask on before you put anybody else's mask on. If the providers are down, man, we're in trouble.
Yes. So I think first of all, I think all our healthcare providers, right? They have the empathy to the patients. I deeply believe in that. Right? So they're well educated, well trained, and they have their various kind of like attitude and professionalism. All those things are fine. So the AI system that are not having enough, I guess, empathy to our target user, aka the healthcare providers yet, mainly because sometimes or most of the times that once we have a good AI algorithm, we got the paper published, and then someone want to see how they can be, implemented in the real world. And when we are implementing those real world systems, we start with so-called perfect or better than human performance algorithm, and we are trying to say, like, look, if the human are not using our algorithm well, it's human's problem. But that's not the case, right? So it's a wrong. I believe it's a wrong kind of like a origination of how we started this whole thinking. Right? We have a good algorithm, we want to implement it, and then human are not using it well. It's human's problem, and then the system being abandoned. Right? It's problematic, but sadly, it's what's happening in most of the days. Right? What we really need is this what we call, we all understand it, user-centered design approach. Right? What users really want. Right? Maybe they don't want a GPT-4, ChatGPT. Maybe they simply want some, one less click, right? So they simply want one less click in their EHR system so that they can save like thousands or hundreds of thousands, clinicians, 2 seconds of time, right? That's what they want, but unfortunately, we're not doing it. Why? Because the engineers and designers who are doing it are not getting like well paid in comparison to, oh, if you say you implemented a ChatGPT functionality into Epic, right? So I think that's where the problem is, and that's what we as a academic researchers, we actually have the luxury time and energy to keep driving this. Say look, this is what the user really want. This is the right approach. Maybe you're not getting direct or immediate incentive, but your user will be much happier, right? So that system that people use is the fundamental ethic system. That's what I always want to argue.
Well, as much as I would like to keep this conversation going for a while, I'm getting a flag from across the room that our time is nearly up. And so I just wanted to take our last minute to just thank everybody for being a part. Jen Briselli, Jessica Floeh, Cecilia Landa-Avila, Dakuo Wang, and Susan Mello. Thank you very much. And I don't know if we solved anything here today, but I think we unpacked a few things for deeper thinking. Thanks for being part of the Center for Design's conversation series. I'm looking forward to next week. We have Sankalp Bhatnagar and his research team will be joining us to talk about a casebook of design-related law practice that they're building. So law in the practice of design. Please join us again the same time next week. Thank you very much, and look forward to seeing you at a future event.
Thanks, everyone.
Thank you so much.